everyone, and welcome to this webinar series on Clostridioides difficile that is organized by the European Society of Neurogastroenterology and Motility, together with the Gut Microbiota for Health of ESNM. I'm Giovanni Barbara from the University of Bologna, and today we are going to talk about the treatment options for Clostridium difficile. And we have two speakers. We couldn't have better speakers tonight, I can tell you. For the first line management, we have Nicola Petrosillo from Rome, Italy. And then we are going to talk about fecal microbial transplantation as an option for treatment of Clostridium difficile infection. And we have Gianluca Ianiro, again from Rome, Italy. So tonight it's an all Italian faculty. So we are not going to talk in Italian, we are going to talk in English. Before we start, I must say that we have to thank Ferring for the support of this webinar series. And thanks to them, we can provide you these presentations tonight. A few housekeeping information for the attendees. Here are your control panel buttons. If you use a computer, you can use basically mainly the Q&A button. In that, when you open, you can place questions either during the presentation or at the end of the presentations, and these will be addressed at the end of the two presentations. In case you encounter difficulties, technical problems, you can use the chat, and that is to communicate something to the organizers. Basically, you will not use the raise hand button because that will not be addressed during the presentations. If you use a mobile phone, basically you have the same buttons, and again, you can use the Q&A mainly. And when you click, you have to be sure that you send through the system your questions so we can see it and addressing the questions during the Q&A session. Again, the chat, as I told you before, if you encounter difficulties. And now I would like to of several presentations around the Clostridioides difficile infection that ESNM organized. You can see here our webinar is getting to the end of this series. Forget if you're interested also in the other two last topic, that the next meeting will be October 12 with the prevention of recurrence and reinfection, another very interesting topic in this theme. So you can register now for that event. Now, without taking any further time to the speakers, I would like to introduce Nicola Petrosillo. Nicola is well known in the field of infectious disease worldwide because he's a great expert. He has been for more than 20 years director of infectious disease at the National Institute for Infectious Disease Spallanzani in Rome, and since mid-2021 is head of the Infection Prevention and Control of Infectious Disease Service at the University Hospital Campus Biomedico in Rome. He has many important offices in the field of infectious disease, and is author of more than 400 papers in peer-reviewed journals in the field of infectious disease. He is also editor-in-chief of Infectious Disease Reports. So please, Nicola, thank you very much for joining us today. And the title of your presentation is First Line Management. Thank you very much.
Thank you, Professor Barber, for your incredible presentation. Myself, I want to thank also the organizer, and I'm going to share the screen. Okay. Okay. My presentation is on the treatment, on the first line management of Clostridioides difficile infection. And as you can see, these are my company interest disclosure. There are several points to be addressed. To address this question, I'm showing you two recent updated guidelines. The guideline from the Infectious Disease Society of America and Society for Healthcare Epidemiology of America, and the guideline from ESCMI, the European Society for Clinical Microbiology and Infectious Diseases. The first guideline from ITSA and SHARE deals with some questions, which is the initial C. diff treatment in patients with initial C. diff infection episode. Should fidaxomicin be used rather than vancomycin? This is a very interesting question because fidaxomicin has been recognized recently as a first option for the treatment of C. diff for its potential to reduce the risk for recurrence. So the recommendation from the American Society is that for patients with initial C. diff episode, the panel suggests using fidaxomicin rather than a standard course of vancomycin. Of course, this recommendation places high value in the beneficial effects and safety of fidaxomicin, but as you know, fidaxomicin is more expensive. The implementation of this recommendation depends upon available resources. And the panel said that vancomycin remains an acceptable alternative. You can see the recommendation is fidaxomicin 200 milligrams given twice daily for 10 days. In alternative, vancomycin 125 milligrams given 4 times daily by mouth for 10 days. And if all these agents, fidaxomicin and vancomycin, are not available, then metronidazole can be given in the dosage of 500 milligrams 3 times daily by mouth for 10-14 days. And which are the evidence from the literature of the beneficial effect of vancomycin over the other competitors? Because it's very important that to see that 4 randomized control trials show the sustained response of CDI with a follow-up of 4 weeks after the treatment for fidaxomicin compared with the other with vancomycin. You see that the difference is statistically significant in terms of prevention of recurrence. Both vancomycin and fidaxomicin are as effective in the treatment of primary episodes. The higher sustained clinical response associated with fidaxomicin may be especially of benefit in those patients who have a higher risk for CDI recurrence, and mainly according with the American guidelines, these people should be chosen between among people older than 65 years with immunocompromission, with severe CDIs, and the panels also identify some ribotypes like O27, O78, 244, because they are more severe infection. However, the potential added benefit of fidaxomicin in this group of higher risk has not been studied in prospective randomized clinical trials. The second question from the American guideline is, in patients with recurrent CDI episode, should fidaxomicin be used rather than vancomycin? And the panel suggests that in this patient with recurrent CDI episode, fidaxomicin in standard or extended pulse regimen, I will explain later what is the extended pulse regimen, should be preferred rather than a standard course of vancomycin. So fidaxomicin better than vancomycin. However, vancomycin in a tapered and pulsed regimen or vancomycin standard course are also acceptable alternative for a first CDI recurrence. But when the recurrence are more than one, multiple recurrence, then other options should be given. Vancomycin, tapered and pulsed, vancomycin followed by rifaximin, and Gianluca will explain later the beneficial effect of fecal microbiota transplantation. And here you can see the recommendation for the first CDI recurrence, fidaxomicin 200 milligrams given twice daily for 10 days, or this is the other option, twice daily for 5 days, followed by once every other day for 20 days. This recommendation comes from a study. The first name is Benoit Guéry on this kind of fidaxomicin schedule. In alternative, vancomycin by mouth in a tapered and pulsed regimen, and you see what is a tapered and pulsed regimen, 125 milligram 4 times daily for 14 days, 2 times daily for 7 days, once daily for 7 days, then every 2 to 3 days for 2 to up to 8 weeks. In alternative, also vancomycin in a standard dosage can be accepted. And in some cases, bezlotoxumab, the monoclonal antibodies against toxin B, can be given during administration of standard of care antibiotics. In case of second or subsequent CDI recurrence, fidaxomicin, vancomycin, and even fecal microbiota transplantation should be considered. And this is the summary of the findings for which fidaxomicin should be used rather than vancomycin. 3 randomized clinical trial in which there is a sustained response of CDI in the follow-up 30 days after the end of treatment. And you see the difference is significant. The third question is, in patients with the CDI episode, should bezlotoxumab be used as a co-intervention along with standard of care antibiotics rather than standard of care antibiotics alone? And the panel suggests that for patients with a recurrent CDI episode within the last 6 months, to use bezlotoxumab as a co-intervention along with standard of care antibiotics rather than standard of care antibiotics alone. And you can see the evidence from the literature. There are at least 2 randomized clinical trials that demonstrate that bezlotoxumab associated with standard of care is more effective in reducing the recurrences for C. diff. Of course, this recommendation of bezlotoxumab plays high value on the potential clinical benefit consideration because bezlotoxumab can be expensive. In settings where logistics is not an issue, patients with a primary CDI episode and other risk factors for CDI recurrence, I remind age, immunocompromission, and severe CDI on presentation, can have a benefit from receiving bezlotoxumab. However, data on the use of bezlotoxumab when fidaxomicin is used as a standard of care antibiotic are limited. And the FDA warns that in patients with a history of congestive heart failure, bezlotoxumab should be considered with caution. cautiously. What is the best, and these are the guidelines from the European Society of Clinical Microbiology and Infectious Disease. This is the update in 2021. 2021 is also the date of the issue of the American guidelines. So the first question is, what is the best treatment for the initial episode of CDI? And the Europeans say that in case of non-severe CDI, first of all, stop antibiotic therapy if possible with the inciting antibiotic and closely monitor the patient for 48 hours in case of non-severe CDI. But if C. diff is mild or severe for the initial episode of C. diff, the panel recommends fidaxomicin 200 milligram twice daily for 10 days. And when the access to fidaxomicin is limited, a risk stratification for the selected use of fidaxomicin should be done. The risk stratification, according with ESCMID panel, is that the fidaxomicin is recommended whenever the clinician deems the risk of recurrence high. And the risk of recurrence is high in their consideration in older age patients more than 65 years, plus the presence of one or more additional risk factors. Of course, one or more means that the risk of recurrence is higher with more risk factors present. And the risk factors are healthcare associated C. diff, infection, prior hospitalization in the last 3 months, use of concomitant antibiotics, PPI started during or after CDI diagnosis, protein pump inhibitors during or after CDI diagnosis, and of course a prior CDI episode. The question on the best treatment for initial episode of C. diff continue with when fidaxomicin is not available or feasible, and this is not uncommon, oral vancomycin 125 milligram 4 times daily for 10 days is a suitable alternative. The difference in these guidelines regarding oral metroneedles of 400 milligram 3 times daily for 10 days should be used only when vancomycin and fidaxomicin are not available or feasible. And the use of vancomycin, the dosage of 500 milligram 4 times daily, is not recommended. This is a strong recommendation. Again, the administration in extended schedule of fidaxomicin, according with the paper published by Benoit Guéry on the Lancet Infectious Disease 2018, it's the use in extended schedule of fidaxomicin, as we said before. This should be given especially in other hospitalized patients. And the panels suggest to consider to add the benzlotoxumab to oral standard of care treatment for a patient with an episode of C. diff infection with increased risk of recurrence when fidaxomicin is not available or feasible. So when fidaxomicin is not available and the risk is high, please give benzlotoxumab according with European guidelines. The second question to be addressed is, what is the best treatment for severe and severe complicated CDI? The options for the treatment of severe and severe complicated include vancomycin 4 times daily for 10 days, 125 milligrams, or fidaxomicin 200 milligram twice daily for 10 days. There is no superiority of one against the other one in terms of the cure of severe and severe complicated. For severe CDI, the routine addition of intravenous metronidazole to oral standard of care is not recommended. This is an important recommendation for a very used, very common practice. And what is the best treatment? Again, when a patient is deteriorating or progressing to severe complicated C. diff infection during anti-CDI antibiotic therapy. The addition of intravenous tigecycline, 100 milligram as loading dose, then 50 milligram twice daily. It's a very interesting option and should be considered on a case-by-case basis. Of course, in this severe and severe complicated infection, consult a surgeon to consider eventually a total abdominal colectomy or partial colectomy or loop ileostomy. The third question, what is the best treatment for C. diff infection when no oral treatment is possible? And when oral therapy is not possible, intraluminal gastro or coloscopic delivery of vancomycin or fidaxomicin is a good practice statement. And in these cases, the panel suggests to consider adjunctive treatment with intravenous metronidazole, or better intravenous tigecycline, again, at the dosage that we said before. For refractory CDI infection. Refractory CDI infection is a very important condition. When non-complicated CDI is not responding to CDI treatment, the patient is not deteriorating or progressing, we should reevaluate carefully the diagnosis of CDI. Maybe it could not be CDI, could be something else. And we have to consider an alternative diagnosis. We should always consult a surgeon as soon as a patient's conditions are deteriorating and the patient is not responding to CDI treatment. And Gianluca will say later on something about fecal transplantation. The fifth question is, what is the best treatment for recurrent CDI? And this is very interesting. This is a new indication guidelines. If the initial CDI episode was treated with vancomycin or metronidazole, then the panel suggests to use fidaxomicin for recurrent CDI. Fidaxomicin is the preferred agent to treat the first CDI recurrence. But if the initial CDI episode was treated with fidaxomicin, the panel suggests to consider addition of bezlotoxumab, when of course is available and feasible, to an oral standard of care antibiotic treatment. It could be vancomycin or fidaxomicin as well. Consider also vancomycin tapering pulse scheme for recurrent CDI when fidaxomicin or bezlotoxumab are not available or feasible. So if you don't have fidaxomicin or bezlotoxumab in your pharmacy, vancomycin tapering pulse scheme can be a valid option. What is the best treatment for multiple recurrent CDI? And this is a field in which Gianluca will say something more in the next presentation. The seventh question from the European Society of Clinical Microbiology and Infectious Diseases is very important, because they try to identify which are the prognostic factors that can identify patients at risk for recurrence of CDI. Older age is more than 65 years is the most important factors for recurrent CDI. Of course, prior CDI episode is a condition predisposing to recurrences. Patients with healthcare-associated CDI and prior hospitalization in the last 3 months are considered at increased risk for recurrence. Patients with concomitant non-CDI antibiotic use after diagnosis are at higher risk for recurrence of CDI. Patients using protein pump inhibitors started during after considered at increased risk for recurrence of CDI. At the conclusion, one interesting point is there a room for prophylaxis for prevention of CDI, probiotics, routine administration of probiotics to prevent CDI when the patient is on any antibiotic treatment is not recommended, has no value for preventing CDI. Routine prophylaxis with anti-CDI antibiotics, there are people giving that give vancomycin in prophylaxis in patients with systemic antibiotic treatment. This is not recommended because there is no efficacy of this kind of prophylaxis. And finally, this is the algorithm that can be used. You can see the standard of care, the high risk recurrence, the preferred options not available when the preference options are not available when it's severe CDI or complicated refractory severe CDI. This is initial CDI, first recurrence, second recurrence. I wish to thank you for your attention.
Thank you very much. I would like really to thank you, Professor Petrosillo, for this beautiful overview and with a lot of attention to clinical practice, bringing to us, to the audience, the guidelines, the updated guidelines on the treatment of C. difficile. I think that this is very important because my impression is that at least in Italy, where I have more perception about the clinical practice in different hospitals, many of these guidelines probably are not fully applied because of many reasons, because of costs, because of local problems, and also because mainly these are news that are coming out from the literature and the randomized control trials that probably will get a little bit of time in order to be well known by everybody and applied in clinical practice. So I think that we can address some of these issues during the Q&A session at the end, and we thank again Nicola for his presentation, and we now move to the second presenter, and it's a pleasure for me to introduce Gianluca Ianiro. Gianluca, beside being a very good friend and also we work together in some projects, I must say that he's a very talented young physician and investigator and researcher. This is a personal impression, but this is deeply confirmed by many others, as for example, he has been awarded as UEG, European Gastroenterology Association, as a rising star in 2020. So this is a very important prize that UEG gives. He is a gastroenterology at Digestive Disease Center of the Fondazione Gemelli IRCS in Rome, and adjunct professor in gastroenterology at the University Cattolica del Sacro Cuore in Rome. And he is an expert, and his publication testimony this in the field of gut microbiota and fecal microbial transplantation. And we should remember that Rome is at the center in Europe for experience and education and research in the field of fecal microbial transplantation, because there they have with Antonio Gasbarrini, my friend Camarota, Gianluca, and the big group working on this, a huge center and experience in this field. So there could be not a better speaker to address the task of fecal microbial transplantation for C. difficile. Gianluca, please.
Thank you, Giovanni, for the very nice presentation. Thank you, ESNM, for the invitation. Okay, can you see my screen?
Yes, Gianluca.
Perfect. I will give a more ecological perspective of the use of fecal microbial transplantation in a Clostridium difficile infection. Clostridium difficile infection is basically a disease of the imbalanced microbiome. Microbiome has been defined as a permanent itchicker as it goes where the driver, where our life brings the microbiota, based on the individual choices and events of our life, on socio-cultural variables, including our religion, our collocation in the social environment, and in a community environment. Think about, for example, if just under your house you have a fruit and vegetable shop rather than a McDonald's, think about how it can change your microbiota, as maybe you are running late at home from job and you have just to buy food just close to your house. Think about also the agricultural industry and market decisions. Think about the governmental and the global decision. Think about how this current crisis can influence your food and nutritional choices, and how it can drive to a different microbiome of all of us. Basically, we know that the more the society is westernized, so the more we live with a Western lifestyle, and the less the human microbiota is diverse. This is really important because the gut microbiota diversity is a marker of human health. If you take all the chronic inflammatory disorders, they share basically a drop in the human microbiota diversity. And if you take the Clostridium difficile infection, you can see a huge decrease in diversity given by antibiotic therapies. And basically, you can see this profile with predominance of C. diff and of few proteobacteria, which are the pro-inflammatory bacteria, and a huge decrease in all the other beneficial bacteria. We, with fecal microbial transplant, aim to restore the dysbiosis that can be driven by several events in our life, that can drive to different disease. We aim to restore dysbiosis to contribute to the health of the individual, of the patient. The basic fecal microbial transplantation working protocol stands in three main pathways. One is the donor screening, one is the preparation of the material, and one is the delivery. The donor screening aims to rule out mainly risk factors for infectious disorders, to rule out the assumption of drugs that can impair the gut microbiota, or the disease that can impair the gut microbiota, with a questionnaire. Then the patient, the donor, undergoes stool and blood exams to exclude transmittable disorders, and a questionnaire before each donation is given to the donor to exclude issues that has been risen during the screening and that can impair the stool preparate. The infusate can be prepared with a fresh material, or can be frozen. If the center has a lot of requests, it can freeze the material, and it is also the most common kind of preparation for FMT. And the fecal material can be delivered through several routes of delivery, including the upper GI, but it is a bit abandoned because of several adverse events, and by colonoscopy or enema, and more recently by capsules that probably are the future way of giving fecal microbial transplant, also because of its disseminability. But why FMT has been used so widely for C. diff, and why it has been introduced even in the international guideline in such a relatively limited time? The first reason is that C.diff is a very simple model of dysbiosis. As I told you before, C.diff includes the predominance of few bacteria, including C. difficile and other few bacteria that can resist the predominance of C. diff. And it also has been identified as a disease of lack of some metabolites. We know that some beneficial bacteria are able to deconjugate the primary bile salts to secondary bile salts, and the primary bile salts are able to promote the C. diff germination, while the secondary bile salts block this process. So basically, with the use of antibiotics and the clearance of beneficial bacteria, the secondary bile salts drop, the primary bile salts predominate and promote the germination of C. diff spores. The second reason is an epidemiological reason. We know that FMT has appeared just when a C. diff infection has been becoming a burdensome disease with more than 29,000 deaths in the UK for a total expense of more than 5 billion per year. And we knew that the real game changer in this process was not the incidence of new cases, but rather the incidence in recurrence, even because due to the resistance to antibiotics, the recurrent Clostridium difficile infection is more likely to present with a severe clinical picture that can drive to several complications and deaths. The third point is that FMT has been incredibly effective for this disorder. This is just a non-comprehensive list of all the trials, the randomized trial and the systematic reviews and meta-analysis that show that the average cure rates of CDI for FMT ranges between 85, 83% to 100%. So it is a complete game changer over the vancomycin, for example. We know also that FMT is effective again in preventing the complication of recurrent CDI, including the severe Clostridium difficile infection. We know that specific protocols are able even to increase the success rate, including the sequential FMT, so it means the repetition of infusions. And as you can see here, this is a couple of pictures from our endoscopy clinical practice. This is at the left, you can see a very bad severe CDI with a pseudomembranous colitis at the endoscopic appearance. And as you can see here, the large bowel is being completely healed from the pseudomembranous colitis thanks to sequential FMT. We know also that FMT is able to reduce the need for CDI-related surgery. We remember that CDI-related surgery has a huge rate of mortality. And if you give FMT to the patient before the situation is critical, you can prevent this kind of surgery with all the costs, but also all the mortality that it brings. Another finding is that FMT is able to decrease the risk of bloodstream infection of 4 times to decrease the length of stay in these patients from nearly 30 days in this observational cohort to 13 days. So it means that it saves a lot of money. So every healthcare system should consider this data. But overall, that FMT is, rather than antibiotics, is able to increase at 31% the overall survival. So it means that restoring the microbiota, restoring the dysbiosis increases the likelihood of surviving of these patients. For these reasons, FMT has rapidly become an established treatment option to manage the recurrent Clostridium difficile infection. We know that FMT has been included in the guideline for the management of C. diff from the ESCMID, from the AGA, or from the Infectious Disease Society of America. And it has been also object of several consensus conferences to develop a consensus on how to perform FMT at the best practice. Anyway, FMT in clinical practice is still under diffused with huge gap between different countries. In this web-based questionnaire released to the European FMT centers, 2.6 inhabitants for 100,000 received FMT for CDI, covering nearly 10% of the patient who could have benefited it. Anyway, the participants in centers had showed an high safety standards and an adherence to the international guideline, but anyway, we found a significant gap in the coverage of FMT. That suggests that the need to raise the awareness and increase the FMT activity, at least in Europe, to cover this huge need. But anyway, we have current barriers that prevent the diffusion of FMT in clinical practice. The first one is the safety. We know that a safety alert has been released by the FDA in 2019 because of 2 deaths related by transmission of SBL producing Escherichia coli strains from the feces donor in an FMT trial to 2 immunocompromised recipients with 1 death. But as an FMT community, we replied through an analysis of all the major stool banks that has shown no serious adverse event in more than 45,000 FMTs, sustaining the theory that the adherence to the standard screening protocols can prevent these kind of issues. Also with the COVID era, FMT has been facing a huge issue because the SARS-CoV-2 can be transmitted by feces. So an alert to stop, an international alert to stop FMT has been launched at that time. But the cure of a Clostridium difficile infection represents a clinical priority. So as a European FMT group, we released some guideline to continue keeping FMT in clinical practice in a safe way with success. But more generally, there are some other barriers that prevented the diffusion of FMT, not only safety, but also the lack of dedicated center, because believe me, building an FMT center is and a stool bank is a real full-time job with a lot of bureaucracy to be satisfied, and also to a donor recruitment that should be continuously continued and continuously fostered, basically. As FMT represents a necessary treatment option to manage the CDI, its provision should be continuously available without any shortage and any stop. In this case, the stool banks can be the solution to all these issues, because they can assure a high quality control and a high safety level. They can replace the need of the lack of the dedicated center, because basically you can ask just the stool bank for the feces and do just the provision of the material without thinking about the recruitment of donors and the preparation of material. They can take care of all the bureaucracy in a central way, and there is no matter of donor shortages because they continually recruit the donors. 2 journal papers have been released by probably mainly the same authors. One, the Rome Consensus Meeting, is more a theoretical approach, while the UAG and the HMSG guidelines are more than a cookbook, but the authors are more or less the same. And finally, think also about when the stool bank cannot reach specific areas. Think about that there is a solution from the industry. what I call the FMT 2.0, so the synthetic microbial consortia. There are two products to date. One is the RBX 2680, one other is the CR109 that have proved the similar benefit rather than the classical FMT on recurrent CDI. This is particularly interesting not only because of the C.diff, but mainly also to expand the use of FMT in chronic disorder, in chronic non-communicable disorder, where we don't need just a healthy biomass, but when we need a specific microbial signature. So mainly this kind of synthetic consortia allow a kind of targeted modulation of gut microbiome. Finally, and then I conclude, I believe that we need also a cultural shift, because today there is a gap between the microbiome basic scientists that study microbiome and the clinicians that are involved in curing the dysbiosis-related disorder. There is a time of a translational figure, the microbiome clinician, who is able to know the different dysbiotic profile and of GI and extra GI disorder, is able to interpret a microbial profiling report and to apply the microbial-based research in clinical practice. So he knows also the associative and mechanistic data. He has expertise in microbial modulation, so with FMT, but also with antibiotics, pre and probiotics. And he works within a microbiome clinic, so with a multidisciplinary team, with a computational biologist, a microbiologist, a nutritionist, an immunologist. When he has the availability of microbial sequencing tools, including not only the 16S, but also the shotgun sequencing, it should be connected, this microbiome clinic, to a stool bank and an FMT center. It should be an hotspot for not only microbiota research, but also for education and networking in this setting. Thank you very much.
Thank you very much, Gianluca. This is a very, very nice and important presentation on an option that we have for our patients, certainly for C. diff infection, and maybe in the future for other indications. Research is going on in this field very rapidly, and maybe also for other diseases we can apply this interesting methodology. I think that we can start with the questions that come from the audience, and the first question is about the use of, here they say prebiotics, but I think is also probiotics. Is there any role for probiotics and prebiotics in C. difficile infection? First, maybe Nicola can start with his impressions.
I think that they refer to prebiotics that are substances that are given to increase the growth of good microorganism in the gut. I think that's it's very interesting, and I know that in some countries in the United States they are studying prebiotics for the prevention, even for the treatment of recurrences, but we don't have evidence from the literature that these substances are effective. But maybe Gianluca or even you, Giovanni, can have some other opinion on the use of prebiotics.
Well, I think that probably in prevention, as you said, Nicola, could be an option. But I think that when the infection is up and running, there is very limited possibility that a prebiotic can revert that inflammatory process and the infection going on. So I think that in a preventive manner, and I think that Gianluca also showed us that the risk of depleting our microbiota from important groups with the preventive type of action in the microenvironment of the colon is another risk factor that we have to take into consideration in the Clostridium difficile infection. And so this is very important. I don't know if you, Gianluca, want to add something.
I'm totally in line with your thoughts. Absolutely. Prevention is the key, not during the active infection.
Okay, so another question from the audience, maybe someone who knows you, Nicola. He says, great presentation, Nicola, thank you. So it seems that he knows you. A question, when you use fidaxomicin, do you use the 10-day bis-in-die regimen or the prolonged bis-in-die, then OD once daily, 20-day regimen? So about regimens.
Okay, this is Giorgio Zanel, that is a great scientist, great microbiologist and pharmacologist, a very friend of mine. George is correct. This is the use of the study by Benoit Guéry, published in the Lancet Infectious Disease 2018, compared the extended use of fidaxomicin at the dosage that I said before versus vancomycin, and showed that in individuals at higher risk for recurrence, mainly patients older than 75 years of age, the extended fidaxomicin use it's effective. It's better than vancomycin standard of care dosage. In my, even though the study is well done and not many clinicians use extended fidaxomicin, mainly for the cost, because it's much costly. In my experience, I used extended fidaxomicin in patients with aged more than 70 years old and with two risk factors for recurrence. But we don't have randomized clinical trials is better than the normal course of fidaxomicin for the treatment of CDI and for the prevention of recurrences. Anyway, it's a very good option. Thank you, George.
Going on with the selection of the patients, I think that what you presented regarding the selection of the patient for the fidaxomicin treatment, I think that everything is very reasonable. So age over 65 and the presence of immunodeficiency and other factors. I'm wondering whether as a clinician, as physicians, we should take into account other factors. Do we have laboratory tests that can help us in the decision, like a high PCR or the severity of the infection as measured with any indicator, fever, or other ways of assessing systemic also spread of the infection? What is your impression about this?
This is a very good point. I'm waiting for quantitative measures of the toxins in the stools as a discriminator for the severity of infection, but we don't have enough experience on the quantification, the measure of toxin in the stool. But in the future, maybe we will have laboratory indicators for severity, and because the classical risk factors are always the same: age, protein pump inhibitors, severity, and prior episode of CDI. And this is not comprehensive of all conditions for the risk of recurrence. So I think that in the future we have a need for laboratory markers.
Okay, now moving to other questions that are coming through. is there still some role for metronidazole? I think that you, Nicole, addressed this very well in your presentation, but maybe you want to say something more.
I think that metronidazole should be given only when fidaxomicin and vancomycin are not feasible or available.
Thank you. Now to Gianluca, safety issues with FMT and the potential of new approved FMT-like products to be safer. Regarding safety, you published something related to the screening of the donors for SARS-CoV-2 infection. And now I was wondering, since we had a discussion with our microbiologist just a couple of days ago, and we started screening also for monkeypox virus in our donors. I was wondering if you're doing the same, because the cases are very limited. We have Nicola that can tell us more about the epidemiology, but we cannot risk, obviously, to transmit these infections.
Yeah, this is really a hot topic now, and as European FMT network, we are releasing a recommendation about this. Basically, we are following the FDA position, so not to include any more lab screening, so not increasing cost and whatever, but just to assure that the potential donor has not had any risky sexual behavior, but this has been already addressed before. And because the current outbreak basically transmitted by sexual contact, differently from the previous ones. And the other point is that there is no close contact with someone who has the monkeypox or is suspected to be to have a monkeypox. So basically, there is an expansion of the screening, but not on a laboratory point of view, but just on a questionnaire point of view.
Yeah, I've seen the guidelines, and actually we started checking the donors, but I think that now we are going to apply that, which is probably enough safe. And regarding the question from the audience regarding the safety of new products that you mentioned at the end of your presentation, that could eventually, in a perfect world, replace what we are doing now, which is a little bit rough. Maybe in one perfect world, we can have a magic pill that replaces an FMT. So do you think that this is safer? FMT is already safe, but maybe this can increase even more safety?
If you follow the rules and the stool banks follow the international rules, basically FMT is safe. But the advantage of the artificial consortia are not on safety, but rather on 2 points: on the reproducibility, because if you want a specific microbiome, you can find a specific donor, but that donor is not eternal, it's not a frozen microbiome that will be the same for the rest of his life. Yeah. Because the first antibiotic therapy that he takes, the microbiota will change. So you won't have anymore the perfect donor. I mean, the one is reproducibility, the other one is the precision. You can basically build a specific microbial signature that can help in a specific disease. Obviously, you have to know the microbial signature or the metabolic signature that can be produced by that bacteria before putting them together.
Thank you. We have a question now for Nicola. I think that comes maybe from Thailand, looking at the name. And the question is, what about fidaxomicin for children, which is a rare disease, but I think that we should give advice also on this.
Yes, this is a very important point, because in February 2020, 2 years ago, the FDA approved the fidaxomicin for the treatment of CDI in children aged more than 6 months. Over the past 2 decades, CDI incidence nearly doubled within the pediatric population, and mostly of cases are community-acquired CDI. There are studies in which more than 2/3 of pediatric CDI is a community-acquired CDI. So the studies are limited by many considerations, but there is a clear trend toward the increase of CDI, especially community-acquired CDI within the pediatric population, and fidaxomicin could be a good option for the treatment in this population.
Okay, now we have 1 minute because we want to finish on time, and I would like to ask you a question, a similar question to both of us. These are the algorithms that are provided by the most important societies, and obviously there are algorithms that are written by infectious disease experts, but there are also proposals from people that come from the gastroenterology field that think that the microbiota is at the center of the world. So if you, Gianluca, would have the power to place FMT in the algorithm, where would you put it?
Oh,
at the beginning.
No, to date there are no studies that compare the cost effectiveness of FMT in preventing recurrence if used as first-line therapy. But I believe that as first-line therapy, the current antibiotics basically work. I would maybe put it a bit earlier, so as the first recurrence.
Nicola?
I agree. I would stratify the risk for people, and I think that we need to work together. Infectious disease specialists, infectious disease people working with C. diff, because infectious diseases are working with so many diseases, including COVID, monkeypox, whatever. But people working with C. diff, infectious disease people, gastroenterologists, microbiologists, and all the people working. And I think that I agree with Gianluca that after the first recurrence, FMT can be considered, but maybe for very at-risk people, and we have to study better the risk stratification.
Yeah, and we have to disseminate, otherwise you cannot propose it in a guideline if province hospital cannot reach this kind of treatment.
This brings us to the end of our webinar, and I cannot close without thanking very much, first of all, the speakers, Nicola Petrosillo, Gianluca Ianiro, that have found the time to stay with us today and educate us on this important topic. The European Society of Neurogastroenterology, Motility and Gut Microbiota for Health for providing this platform and this series of webinars, and also Ferring for giving support to this educational initiative. And I would like to remind you that we have another webinar on this topic, and particularly prevention of recurrence and reinfection on October 12, and you can register now. Thanks also to the audience for being with us today, and I wish you a very good rest of the day, and thanks again for being with us.
Bye.